So we will talk about hormonal control of calcium metabolism now. And I think you all are familiar that calcium is regulated via a few hormones. Okay. So if you look at calcium balance in the body, the only source of calcium is dietary calcium, and 99% of the calcium which is in our body is actually present in bones and teeth. It's only 1% which is present in the fluid, which is mainly the blood. And it is that calcium which is physiologically important, the one which is present in the blood. Now, what are the functions of calcium? I think most of you know different functions of calcium, right? So it is integral component of bones and teeth. That is its structural function, but it has many functions in the cells. It is required for muscle contraction. It acts as a second messenger, right? It acts in cellular signaling. It is part of certain enzymes, works as cofactor or coenzyme. It can switch on or switch off genes. Now, if you look at the maintenance of calcium in the body, we look at vitamin D first. Okay. Now, this is a steroid vitamin which is synthesized in a few steps. The first step occurs in the skin, where under the action of ultraviolet B rays, vitamin D is formed from the parent molecule, that is cholesterol. Okay. Then let me show you the picture first, then we come back to this slide. So this is actually vitamin D synthesis. In the skin, it is formed from cholesterol under the action of ultraviolet rays. Then vitamin D3 is carried to the liver, where liver changes it into 25-hydroxy vitamin D through an enzymatic action. This 25-hydroxy vitamin D is then converted to 1,25-dihydroxy vitamin D in the kidneys. Okay? And this is the active form of vitamin D, which will perform all its functions. It's an enzyme, 1-alpha-hydroxylase. This enzyme is under the control of a hormone, that is PTH, or parathyroid hormone. Okay? Now, if you go back here, the previous slide. Okay. So vitamin D is scarcely found in nature. So the major source of vitamin D in our body is actually synthesis under the skin, the liver, and the kidney. But it is present in certain types of diet. There are 3 tissues that are involved in the synthesis of vitamin D, as I just showed you. And it also affects 3 tissues. It affects gut, where it enhances calcium absorption. It acts on the bone, where it will enhance bone deposition, or calcium deposition in the bone. This hormone is coming from parathyroid glands, which are located just behind the thyroid gland. Okay, there are actually total 4 parathyroid glands, and these glands have what is known as a calcium sensing receptor. So they respond to the plasma levels of calcium. When calcium levels decrease, PTH will be increased, and it will cause mobilization of calcium from the bones into the blood. It will cause formation of vitamin D, which will increase absorption from the gut, okay, and it will decrease loss of calcium from the kidney. So 3 actions of parathyroid hormone. Now on kidney, if you look at its action, it causes reabsorption of calcium. At the same time, it causes increased phosphate excretion. Okay, so it causes reabsorption of calcium, but excretion of phosphate, and it enhances this particular enzyme which I showed you earlier, which is required for the final step of vitamin D activation in the kidneys. Okay. Now, looking at the abnormalities of calcium homeostasis, First, we look at hypercalcemia. If the blood calcium levels are above expected normal range. Now, one thing which I think we have discussed before, whenever you are looking at blood or plasma calcium levels, you have to look at albumin as well, because calcium is bound to albumin, okay, and it's only the free calcium which is physiologically active. So, in order to diagnose somebody as suffering from hypercalcemia or hypocalcemia, you have to measure total calcium, you have to measure the albumin and the free or ionized calcium. Okay. So, patients with low serum albumin would be expected to have low total calcium and normal ionized calcium. Okay. And opposite is true for those patients where serum albumin is high. So, you have to always take into account the serum albumin levels. Make sense? And primary hyperparathyroidism is the commonest cause of hypercalcemia in the population. Okay? So, primary hyperparathyroidism, which means that the parathyroid hormone is produced in high amounts. Okay? There are many other causes. So, top of the list is primary hyperparathyroidism. Then you have secondary and tertiary hyperparathyroidism. So, problem could be somewhere else. Okay. There are other endocrine disorders, sometimes in patients with cancer, where they have metastasis in the bone is resorbed and calcium is released into the blood. So, they can have hypercalcemia. Okay. Certain medications, renal disease, all these things can lead to hypercalcemia. But the commonest cause is primary hyperparathyroidism. Okay. The signs and symptoms of hypercalcemia are very widespread. So, you can have effects on the central nervous system, lethargy, decreased alertness, depression, confusion, ultimately leading to coma. On the GI, you have effects like anorexia, constipation, nausea and vomiting. It impairs kidneys' ability to concentrate urine, so you will be losing a lot of water in the urine. Okay, so it can lead to dehydration. It also increases the risk of kidney stones, because calcium can crystallize in the renal tubules and can lead to formation of kidney stones. And in the cardiovascular system, it can cause or it can exacerbate existing hypertension. Sometimes the signs and symptoms of hypercalcemia are described by stones, bones, groans and moans. So, these are typical presentation of hypercalcemia. Okay. Now, if somebody presents with hypercalcemia, and as I told you, the commonest cause is primary hyperthyroidism, these are the biochemical findings in a patient with PHPT. Of course, you will have hypercalcemia in the blood sample. There will be hypophosphatemia. The reason being, as I told you earlier, PTH causes calcium reabsorption, but phosphate excretion from the kidney. So, there will be hypophosphatemia and there will be elevated PTH levels in the blood. Okay. Because it induces this enzyme in the kidney that converts vitamin D into the active form. So, because of that, what happens, the ratio of inactive vitamin to active vitamin D also changes, because the enzyme is induced at a large extent. So, you will have this disturbed ratio between 25 hydroxy vitamin D and 125 dihydroxy vitamin D. Urinary calcium excretion will be increased, because when you have, although it is causing reabsorption of calcium from the kidneys, but when plasma levels go beyond certain limit, calcium will be lost in the urine. Okay. So, you will have high calcium in the blood, you will have high calcium excretion in the urine as well. Okay. And sometimes you can have metabolic hyperchloremic acidosis, although it is rare, but in severe cases you can even have this type of acidosis. Okay. And serum alkaline phosphatase in severe disease. This is released from when the bone is resorbed, okay, and there is too much bone resorption, you can have elevated serum alkaline levels in the blood as well. Okay. There are certain drugs which can cause hypercalcemia. Some of them are listed here. Thiazide diuretics, which are used quite commonly to treat hypertension. So they can cause reabsorption of the filtered calcium, leading to hypercalcemia. Lithium, which is used to treat depression or bipolar disorders, it can actually change the set point of the calcium sensing receptor in the parathyroid gland. Okay, so it will be set to a higher level, so there will be hypercalcemia. Vitamin A can also, if it is taken in large amounts, can cause hypercalcemia. It activates osteoclasts, which will eat up the bone and release calcium into the blood. Okay. Now, hypocalcemia, the other extreme, where calcium levels are low. Okay. You have to measure the ionized calcium in order to diagnose the patient with hypocalcemia. So, keeping in mind the albumin binding of calcium. Okay. The common signs and symptoms in hypocalcemia are tetany, involuntary contraction of the muscles, usually small muscles of the hands and feet. You have this Shostak sign where you tap the face of the patient and the muscles will twitch and contract. Okay, a numbness and tingling can be there. Under CNS signs and symptoms, irritability, fits, and in chronic hypocalcemia, there could be even personality changes. And under cardiovascular, you can find some changes on the ECG. There is QT prolongation. So the QT interval becomes longer. Heart rate will be lower. There will be bradycardia. Okay. Causes of hypocalcemia. The most common cause is hypoparathyroidism, low PTH. It could be post-operative. Sometimes, as we will see later when we talk about thyroid disorders, sometimes when you remove thyroid surgically, because parathyroid is very small in size, embedded just behind the thyroid, it is very common practice that parathyroids are also removed with the thyroid. Okay, so it could be post-operative. Autoimmune, there is autoimmunity against the parathyroid glands. There are some congenital types, and there is pseudo-hypoparathyroidism. Now, this is the condition where the PTH levels are actually high in the blood, but the PTH receptor is not responding to it. So, when you measure the parathyroid hormone levels in patient's blood, they will be high, but they will be hypocalcemia, because this PTH is unable to bind to the PTH receptor on the target cells and do its function. This is pseudo-hypoparathyroidism. Okay. Deficiency of vitamin D could be due to malnutrition, could be due to malabsorption. Okay, could be due to post-gastric surgery, so on and so forth. Okay, liver disease, kidney disease, where vitamin D is not formed, it's not activated to the final form, you will have hypocalcemia. And if you remember when we were talking about electrolyte imbalances some time ago, we said that magnesium is very closely linked with PTH. Okay, so magnesium depletion can lead to lack of PTH synthesis, lack of PTH release, and even its action on target tissues is affected. So magnesium has a very close link with PTH. Hypomagnesemia can cause hypocalcemia. Okay. There are many drugs which can cause hypocalcemia. Anti-resorptive agents, so those drugs which prevent bone resorption, can cause hypocalcemia. If you see the second drug now, medications that stimulate bone resorption can also cause hypocalcemia. So this is opposite to the first drug, right? So you would think how medications that stimulate bone resorption can cause hypocalcemia. Now these medications, when they stimulate bone resorption, there will be hypercalcemia, right? And what will happen with hypercalcemia? PTH will be inhibited, right? When PTH is inhibited, this calcium will be lost through the kidney. So sometimes medications that stimulate bone resorption can actually present with hypocalcemia. It's a paradoxical kind of effect. Okay, lithium, thiazide diuretics, and patients with hypoparathyroidism, when you give them parathyroid hormone, it can also cause hypocalcemia. Okay. Okay. Now moving on to metabolic bone diseases. They are classified into actually 3 diseases. The first 2 are written here: rickets and osteomalacia. Now these 2 diseases are due to abnormal bone mineralization, and the main cause usually is vitamin D deficiency.
Sorry, Sufyan, can we go back a step?
Okay.
Primary hyperparathyroidism can lead to hypercalcemia, right?
Okay, yeah.
Yet if you give a patient synthetic parathyroid hormone,
Yeah.
it's also saying you can get low, you can get hypocalcemia. Why is that? It seems to be a contradiction.
Recombinant human parathyroid hormone. Okay, now usually, sorry. I think I didn't say it properly. Yeah. You give recombinant human parathyroid hormone in patients who have had parathyroid surgery or thyroid surgery. So their own parathyroid hormone is gone. Okay. Now, when you have parathyroid gland, it will respond to the physiological levels of calcium, right? So it will respond when you're taking a tablet, for example, you're taking a fixed dose of parathyroid hormone. It's not that physiological response that you get normally when you have parathyroid gland there, right? So when you give this parathyroid hormone, then you don't have this kind of regulation of calcium level through parathyroid hormone, this recombinant one. So there is a chance of risk of hypocalcemia in these patients. Make sense?
Yes.
Yeah? Okay. Okay, metabolic bone disease. So rickets is metabolic bone disease if vitamin D deficiency occurs in children. It's very common in developing countries. Lack of vitamin D due to usually malnutrition, okay, and it will have bone deformity. So these patients will have bone deformities, soft bones, and prone to fractures. Osteomalacia is the same thing, but it occurs in adults. So bones have already developed, so there is no deformity of the bones, but there will be weakness of the bones. Okay. Osteoporosis, on the other hand, is another metabolic bone disease which is very common. It is the most prevalent metabolic bone disease in adults. Some statistics from America is given here. Affects around 20 to 25 million Americans, and it is more common in females than in males. Leads to a lot of fractures, especially in advanced age. Diagnosis is based on clinical characteristics and DEXA scan. This is a densitometry. So it's a bone scan basically where you look at the density of the bone. Okay. And of course, another thing is fragility fracture. Fractures occurring at an inappropriate degree of trauma. So usually, for a fracture to occur, there needs to be an appropriate trauma that caused the fracture. So in these patients, little bit of trauma can cause cancer. This is known as fragility fracture. The most common fracture in these patients is the fracture of neck of femur. Fracture of neck of femur. With a little bit of fall, they can have fracture of neck of femur. Okay. Treatment of osteoporosis, there's a wide range of treatment modalities. First of all, you will treat the fracture if the patient already had the fracture. You can modify preventable risk factors such as smoking, alcohol, evaluate the patient's fall risk, the ergonomics, of the environment around the patient, so minimize the risk of falls, so consideration of walkers, handrails, etc. Adequate dietary calcium and vitamin D, and prevention of those with family history, because if family history is there, there are more chances of osteoporosis and its complications. So if there is family history, you have to be more proactive, and you can also give some medications to these patients. But the main stay is basically on prevention. Okay, so this is about osteoporosis. All right, so that's all about calcium metabolism.